am introducing our next speaker, Scarlett Cheong, who is from the University of Minnesota. She's going to talk more about her department and where she works within the U. And her title is Automated Chronic Subdural Hematoma Segmentation with 3D UNet. Scarlett will talk for about 20 minutes, and then we will have 15 minutes of Q&A, and we're going to utilize the microphone for a Q&A session. Thanks, Scarlett.
Awesome. Thank you. Good morning, everybody. Thank you for joining me today for my talk about automated chronic subdural hematoma segmentation with 3D UNet. My name is Scarlett Cheong, and I am a PhD student at the Bioinformatics and Computational Biology program here at the University of Minnesota. I am co-advised by both Dr. Usma Samadani and Dr. Sham. So I have no financial disclosure or any conflicts of interest with the presented materials. So this is an overview of the content I'll be going through today. Okay, so first question, what is chronic subdural hematoma? Chronic subdural hematoma, also known as cSDH short form, is a type of intracranial bleed that occurs between the brain and the dura mater. Let me pull up the laser pointer. So it is between the brain and the dura mater right here. There are many different types of intracranial bleed, as you can see from the picture, but today we are just going to focus on the subdural hematoma, specifically on the chronic. So cSDH commonly develops following a head trauma, even from minor impacts, particularly in elderly patients. Older adults, especially vulnerable to this condition due to age-related changes in the brain structure, combined with higher risk of falls and so on. So the clinical presentation of chronic subdural hematoma can vary from no symptoms at all to the most commonly complained headaches, as seen as in up to 80% of the patients. Confusion is up next, occurring up to about 56% of the cases. And next we have vomiting, aphasia, which is difficulty in speech, hemiparesis, weakness on one side of the body, or off balance, and so on. In a recent study of 778 patients with chronic subdural hematoma in Brazil, as many as 40% of them denied a history of trauma, indicating that chronic subdural hematoma may also arise in conjunction with age-related neurodegenerations. It is evident in the literature that chronic subdural hematoma risk is significantly modified by several risk factors. Among all risk factors identified to date, age has the highest association with development of it. Next we have is getting a head injury or a trauma to the head, being on anticoagulation or antiplatelet therapy, male gender or status as a veteran are also a separate risk factor. This is possibly due to higher incidence of trauma, more frequently alcohol consumption, and many more. Last but not least, alcohol. Due to the increased risk of falls and trauma, brain atrophy, liver dysfunction, inflammatory process, and so on that comes with alcoholism. Chronic subdural hematoma is a relatively common affliction, especially among the elderly, in whom the incidence is estimated to be 7.4 per 100,000 per year. The following data are from a study from Finland. From the highlighted area, we can see from 1990 to 2015, the overall incidence of chronic subdural hematoma has nearly tripled for those who fall on the 80 to 89 age range, while the incidence remained relatively stable for those who are younger than 80 years old. During the same time frame, the annual incidence increased over 10-fold in patients who are older than 90 years old, as you can see in the highlighted in blue. Similarly, when broken down by gender, by sex, both men and women older than 80 years old had an increased incidence of chronic subdural hematoma over the time period. However, men had a much higher increases in incidence than of women. Okay, this table here highlights the mortality rates for chronic subdural hematoma, both at hospital discharge and over time, across several studies with patient cohort averaging between 69 to 83 years old. The overall trend demonstrates that mortality at 6 months My laser pointer isn't working so well, sorry. The overall trend demonstrates that mortality at 6 months is greater, at 1 year are significantly greater than as of in-hospital mortality. Overall, this data demonstrates the increased risk of mortality post-discharging, underscoring how dangerous chronic subdural hematoma can be in an aging population. Here is the survival curve illustrates survival probability over the 10-year period for chronic subdural hematoma patients grouped by age cohort. We can see the first line here is the patient who's in their 60s has the highest survival probability with the more gradual decline. While patients in their 80s in the yellow and patients in their 90s, shown in the blue, show steep declines, particularly within the first few years after diagnosis. So here we have craniotomy, twist drill craniotomy, and burr hole. They are the most commonly performed procedure for chronic subdural hematoma drainage. According to a paper that was published from our lab, as the incidence rate for chronic subdural hematoma is progressively increasing, it will surpass brain tumors as the most common neurosurgical condition by the year 2030. Therefore, the procedures shown will become the most frequently performed neurosurgical procedures. So why is chronic subdural hematoma so challenging to manage, you may ask? Here, we see a chronic subdural hematoma, a CT scan of it. And here's another picture of the acute subdural hematoma. As you can see, the acute is easier to distinguish from the normal brain tissue when compared to the chronic subdural hematoma. So I have circled both the hematoma in case we don't know where it is. The chronic blood just here generally looks way darker, and the acute blood looks way lighter in CT scan. Here are a couple case studies to help us understand the challenges of the chronic blood even further. So we have case study 1 and case study 2. So you may think that the chronic blood ends like where the arrows are for both case study, but it stretches way further than you think it is. So here's the full representation of the chronic subdural hematoma for both cases. Another case study, where is the chronic subdural hematoma? I have circled it for you again, just so you know. And now what does the circle area looks similar to? It looks very similar to the ventricle and the cerebral fluids in the brain. One last case study. Where is the chronic hematoma again? I have circled this one out too. And this chronic subdural hematoma looks so much like the brain tissue that it looks camouflaged, especially for computerized segmentation algorithm. Here I would like to explain some of the CT scan fundamental. So for each pixel in the CT scan is representing a Hounsfield unit. The air we can see here is negative 1,000 Hounsfield unit versus the skull bone has a Hounsfield unit of 1,000. And here we can see the chronic blood has a Hounsfield unit of 22 to 45 range, and it is very similar to the brain tissue. So we can see over here the range, blood 55 to 75, that is the Hounsfield unit for a chronic blood. So if chronic subdural hematoma shows up very similarly to the brain tissue on CT scan, why are we still using CT scan for diagnosis? So now let's talk about some of the advantages of using CT scan for this condition, especially when compared to MRI scans. CT scan is generally faster than MRI scan, making them the preferred choice in cases of trauma and other acute neurological emergencies. And obviously, it's more cost-effective compared to MRI, as they can effectively rule out many neurological disorders immediately. CT scan is less sensitive to patient motion during the examination due to its faster imaging processes. CT scan also provide detailed evaluation of the skull, so physician can assess the bone structure and potential fracture right away. And last but not least, it also doesn't require the patient to enter a confined space for an extended period of time, just like the MRI does, providing more comfort to the patient. So are there any disadvantages of using CT scan for this condition? Here's a picture of CT scan image, as we already seen many times. And here's another MRI scan of the same patient for the same condition. We can see that the MRI shows overall better quality image and better resolution of the brain, but CT scan has all that we need to treat the patient already. So we don't need to waste all this time and money to get an MRI scan. Considering the cost and time taken, ease of availability, it remains as the standard protocol. So why do we want to develop a tool to automatically segment chronic subdural hematoma? Let me tell you a true story about a patient case that my PI was asked to be an expert witness of. A patient went to an outpatient radiology facility, had a CT scan done on a Friday night, but the CT scan wasn't read by the radiologist until Monday morning. During the weekend, he deteriorated and got worse at home, ended up almost dying. He then went to the emergency department and had a neurological procedure done very quickly over the weekend. He survived it. This incident happened because no one read the scan immediately. This could have been easily avoided if we have an automatic screening system where the machine automatically picks up subdural or an abnormal head CT scan and alert the radiologist to read the scan immediately. So what the objective here is? The main objective of my study is to accurately segment out the chronic subdural hematoma region from a CT scan using a 3D UNet model. For many years, convolutional neural network, CNNs, short form, were the mainstay algorithm for analyzing images. They enable automated tasks like image classification, object detection, and basic segmentation with higher accuracy than the previous fully connected network. However, CNNs work primarily in the 2D and are limited in handling the detailed 3D spatial relationship necessary for accurate segmentation in medical imaging. This is where UNet, a specialized CNN architecture, comes in. Unlike the standard CNNs, the UNet encoder and decoder structure combined with the skip connections. God, my laser pointer is not moving as fast as I'm talking. So with the skip connection, it enables it to capture both high-level contextual information and fine-grained spatial details at the same time, making it much better suited for our medical segmentation needs. A 3D UNet architecture is designed to work with 3D data, making it a strong candidate for analyzing medical images that are collected in a volumetric form such as CT or MRI scans. 3D UNet leverages the 3D convolutional layers, allowing the model to process the entire volume at once. This enables it to maintain spatial consistency across slices, which is particularly valuable for chronic subdural hematoma, as this hematoma can have complex, irregular shapes that vary across the brain's 3D space. So let's break down this 3D UNet architecture. The 3D UNet consists of two main parts, the encoder part and the decoder part. The encoder is responsible for downsampling the input volume while learning increasing the abstract feature. In simpler terms, as the input data is passed through multiple layers in the encoder, we're progressively reducing the size of the volume but increasing the depth of the analysis. This captures high-level context essentially for distinguishing the hematoma from surrounding brain structure. Then we have the decoder or the expanding path. The decoder upsamples the compressed data back to the original resolution, reconstructing the original spatial information from the low-dimensional output from the encoder. By doing this, we obtain the detailed segmentation map that retains the original resolution of the input CT. What really sets UNet apart is the skip connections. In a traditional encoder-decoder structure, much of the spatial detail can be lost during downsampling. Skip connection allow us to bypass this issue by connecting corresponding layers from the encoder and the decoder. This connection carry information directly from the encoder, high-resolution layers, to the decoder corresponding layer while preserving fine details. This is essential for achieving pixel-level accuracy in segmentation. Together, this design element make 3D UNet a powerful tool for segmentation tasks involving complex 3D data. In the context of chronic subdural hematoma, this structure enables us to detect and segment the hematoma with high precision, even it presents with irregular shapes or densities. The 3D unit effectively balanced the need for both fine details and contextual information, making it ideal for automated volumetric segmentation in clinical application. So let's dive into how we implement the 3D unit for our data set. My PI, Dr. Samadani, is affiliated with the Veteran Affairs Hospital. Therefore, I utilize the VA database basis of CT scans to gather all my data. VA has a system called Vinci. And this allows us to pull data locally using WiADS or from nationwide using Medicom. Here is a flowchart of how I retrieve the data from the database all the way to storage from our research drive. And then after gathering all the patient's data, I have to do the manual annotation for each CT scan. And they are each verified by my PI, who is a neurosurgeon. Here's a look of how the annotation is done. And once it's done, this is in the 3D view, and this is its corresponding 2D view, 2D labels for each slice. Moving on to the machine learning workflow, we take the input CT scan with its corresponding 3D segmentation label, and then going through a data pre-processing steps, splitting the data into 80% training set and 20% testing set. We have a total of 125 unique patient CT scans and data augmentation to increase the data set, passing them into a 3D unit architecture, which I just explained just now. We use the dice coefficient as the loss function and Adams optimizer with the depth of 4. Last but not least, I then received the predicted hematoma from the 3D unit. Moving on to the results, to evaluate the model performance, we primarily use the dice coefficient, which is the measure of spatial overlap between the predicted hematoma and the ground truth hematoma. Here are the plots of our model training and validation loss over 300 epochs, as well as the training and validation dice score. As you can see, our model does not begin to overfitting, even after 300 epochs of training, and our validation dice score continues to increase. We trained our model for many different epochs and evaluate its performance for each. We found that 300 epochs was the optimal time for our model. Overall, our model achieved high dice score, indicating strong overlap between the predicted and actual chronic subdural hematoma region. For a more intuitive understanding, I've included the visual example of the result. On the left, we have the original CT scan, and then in the middle, we have the manually segmented ground truth hematoma, and on the right, we have the unit predicted output hematoma. You can see there are a lot of similarities between the ground truth and the predicted hematoma, even with the irregular shapes. Here's a look of them overlaying on top of the original CT scan. You can see it predicts it pretty well. For this, another example, I have rotated the CT scan by 90 degrees to evaluate the model's ability to generalize to a different orientation of the CT scan. And as you can see here, it has no problem picking up the chronic subdural hematoma even with a 90-degree rotation. Here are the individual differences in the ground truth and hematoma volume versus the hematoma volume predicted from the 3D unit. The highest difference is scan 12 from the original output with an over-prediction of 13.4 ml, which is highlighted in the yellow color. Then we have used the unit to predict the volume of the blood with the 90-degree rotation of the CT scan. Similarly, both rotations show an average discrepancy of less than 5 ml per CT scan when compared to the ground truth. So there are many challenges that we encounter in this study. One of the primary limitations was a small data set, as I said. A small data set risks overfitting. However, we did not encounter this issue. To mitigate this possibility of overfitting in the future, we would like to expand our data set to include a wider range of chronic subdural hematoma cases. Medical imaging protocol can vary significantly between institutions. Our model was trained and validated on scans from one institution only, meaning it may not generalize well to data from facility with different imaging protocol. And then generating an accurate ground truth label for chronic subdural hematoma is both time-consuming and subject to variability between annotators. CT scan annotation requires expert radiologists and can vary due to subjectivity in identifying the exact boundaries of hematoma. This inter-observer variability introduces noise into the dataset, potentially impacting model accuracy. Finally, deep learning models like UNet are often considered the black boxes due to the lack of transparency of their internal processes, making clinicians slower to adopt to these models. So this model has a great potential to assist clinicians by providing fast, consistent, and accurate segmentation of chronic subdural hematoma, supporting diagnosis and treatment planning. There are several ways that we seek to improve the model, make it better suited for clinical practice. The first will be increasing the data size from multiple institutions to improve model generalizability. Second, we develop a post hoc interpretability method such as heat maps or feature attribution technique that makes the model decision making more transparent to the user. Or use consensus-based or semi-supervised labeling to enhance training data quality and reduce the inter-observer variability. Apply multitask learning for handling cases with other intracranial abnormalities or comorbidities. So here I'm going to tell you what's the long-term clinical direction for this project from my lab. So when a patient comes into the ER with a head injury, they will get their routine CT scan, and the CT scan will automatically be picked up by the machine, and the hematoma will be automatically segmented. Then the minimally invasive robotic surgery will determine the optimal drilling point for the hematoma drainage and perform the surgery. Due to the streamlined and automated nature of the process, the patient will get faster care and therefore leading to a faster and better recovery. So in conclusion, I have successfully developed an automated 3D segmentation model for chronic subdural hematoma. It has high accuracy and efficiency, giving it the potential to streamline segmentation in clinical workflow. It will reduce manual workload, allowing clinicians to focus on diagnostic and treatment planning. With further validation, the model could enhance patient outcome and overall healthcare efficiency. Here are my references, and I would like to acknowledge my mentor, both Dr. Samadani and Dr. Sham, for guiding me throughout this project. And thank you, Minnesota Office of Higher Education, providing funding for this project. And thank you, everybody, for listening, and thank you for the rest of my lab member for your support. I will now take questions from the floor. Clinical implementation?
Yeah, for example, like building out a clinical decision support system or implementation at the VA, for example, since you were using their data set for retrospective validation.
Sorry, I cannot hear the microphone.
Oh, sorry. What are your goals for clinical implementation of this model?
Yeah, so for sure. Okay, I've talked to Mike. So the clinical implementation is, like I said, so right now we are at the very first stage of this clinical workflow, correct? So we want to be able to use this at, the first stage is implement this to the hospital. So when a CT scan, when a patient gets a head CT scan, it will go through the model right away, and then the model will tell you if this scan needs to be looked by a radiologist right away or not. If it's like a normal head CT scan, then it can wait like a usual CT scan schedule. Can be in the line for it, but if this CT scan has some abnormalities, it will just alert the radiologist, hey, this one has to go on top of the line, so that the patient who actually needs care get help first, like patient who has emergency will get help immediately. Yeah. Thank you. Yes.
I also have a similar question. Do you think this can expand beyond the subdermal hematomas
Yes.
into other strokes or different, even like tumors? Do you think it would be something that it can expand upon?
Yes, for sure. Because this specifically is on chronic subdural hematoma because nobody has ever done it. But yes, there's a lot of studies out there, models that can successfully predict tumors, can successfully predict acute subdural hematoma, because those are very obvious to the machine learning models. So machine learning picks them up very fast. And there's plenty of models out there that can pick up tumors, acute blood, and so on already, but no one has really successfully done on the chronic yet because of how similar it is to the brain tissue. But yes, I would like, in the future, we would like to combine all of this together and make a model out of it. And like you said, with other disease that comes with the brain, yes.
If no one has other questions,
Yeah,
I have
for
another
sure.
one. I'm a neuroscientist by training, so
Yeah,
this
for
is
sure.
interesting to me. So another question I have is, what kind of standard like brain 3D like template did you use? Do you use several of them just to get like a good scan of a typical brain?
Yes, so when I go to for each patient, usually they only have like one CT scan, so that's the choice that I have. But if I have multiple CT scan, I will choose the one that closest to their surgical date. So that has like the biggest hematoma on the CT scan that I can segment it really well. Yes, that would be my template.
Do you think there's an age restriction, like an adolescent brain might not be the best fit for this model, or?
Yes, correct. Because adolescent brain is like very different than an adult brain, and my model it's a little bit biased because my model all the data are coming from the VA itself, and people in the VA who got this disease specifically are like older white males and veterans. So this model itself is very biased towards that population. But yes, we are looking forward to expand. And for adolescents or children, they don't really get chronic subdural hematoma because this is an elderly disease as well. Going back to your question, we are looking to expand chronic subdural hematoma from like different institutions, like Fairview, for example. I have already requested data from them to test my model, but probably not for adolescents or anybody younger. Yeah.
Thank you.
Can we get the microphone to the lady there? Thank you.
Thank you. So I'm not really familiar with the concept of robotic surgery or what it entails. Could you go into a little more detail about how the model works
Yes.
in regards to that?
So right now in, for example, brain tumor, there's already robotic surgery that can actually drill your brain and calculate the precise location on how to extract the brain tumor out. But they're using MRI scan because of the resolution and everything. But with the similar concept, we're looking forward to like down the line when we are more advanced into this, we are planning to collaborate with Medtronics and see how they do with the brain tumor. Similarly, the same technique can be applied to this as well. So when the patient comes in, because this will be like one of the most performed neurosurgical procedure by 2030, so it will help offset a lot of neurosurgeons' work if we can successfully implement this. Yep, so it's basically the same concept with brain tumor, but we just have to calculate, because blood is different than brain tumor. When you move, the blood moves in your head too. So where exactly to drill the hole in your brain is a very risky thing, right? So we have to develop a very good algorithm to calculate where to drill your brain first. Once we get that algorithm done, then once you know like where exactly to drill your brain, the robot nowadays can just do whatever you tell them to do. But how to determine where is the optimal drilling point is our next step. Yeah, going forward. Yeah. Any more questions? Yes, gentleman at the back.
One of your advisors has done quite a bit of work in concussion research, and the VA obviously is very interested in that area.
Correct.
Does this tie it all into anything to do with CTE?
CTE?
Concussion, traumatic injury,
Oh,
which shows brain injury?
yes. For my work, no, not really. But my advisor, she does a lot of concussion stuff, so she has separate projects for those. Yeah. Lady.
What's the process for identifying what other conditions might most benefit from faster diagnosis from a similar type of model, whether it's a brain injury or other conditions? Like, how do you identify where you want to invest the time in researching like a model that would aid in better patient outcomes and faster diagnosis like this?
Yeah. So this is my PhD project. So my project is focusing on how to calculate the best. Let me find my slide. Oh no. That's my. Uh-oh. Okay. So, okay, going back to your questions, like, I cannot fix all the procedure out there. I cannot fix all the disease out there. My PhD project is solely focusing on this chronic subdural hematoma segmentation. So, like I said just now, there's 3 types of surgical intervention: craniostomy, twist drill, and burr hole. So twist drill is the most minimally invasive procedure out of the 3. So my project is to calculate, but with twist drill, craniostomy is not preferred, even though it is the most minimally invasive. It's because of the very high reoccurrence rate, because it's only a 4 millimeter drill instead of 14 millimeter drill on the burr hole. However, because of the very tiny hole and chronic subdural hematoma is it's an oblet, so it's kind of like a jello. So it's not fluid-like. You cannot just drain it with a very small needle. It doesn't work that way. So, but for patient recovery outcome, it will be the best because it is minimally invasive. So right now my project is to determine here. So to determine why is this have such a high reoccurrence rate? Are we drilling it on the wrong position, or like do we need multiple holes for the airflow and blood to come out? So that will be my PhD project, but I cannot solve all the problems that comes within the brain. We have to take it one step at a time. Thank you.
I have a question from online.
Okay.
There are many examples of AI triage devices being used in clinic. You mentioned the idea of prioritizing patients with more severe hematomas. Does this automation then lean towards becoming more of a classification than a segmentation task?
This is more like a segmentation. So if you have a chronic subdural hematoma, it will alert the radiologist right away and get look at the scan, regardless of how big or how small the hematoma is. Yeah.
Hi, thank you so much. I was wondering, in your training data set, did you only include patients who did have the chronic subdural hematoma, or do you also include normal brain scans in that as well?
Good question. So for my training data set, I only have the patient with hematoma, with chronic hematoma, because I didn't have the IRB to retrieve a normal patient brain scan. Yeah. Yes, sir.
Just a suggestion, I think you would use a convolution neural network model. I think the each features may be independent. Usually, maybe medical study or biology study, they are high correlated to each other. So maybe you incorporate the dependency before you do running the convolution neural network. Then maybe more useful, I think, or interpretable.
Yeah, thank you. Yeah.
So I just am wondering, you talk about like streamlining it, and the whole point of it is so that the doctor doesn't immediately have to look at the scan. How long, if you were to input new, how long would it take to predict currently? Like if you inputted a new.
You mean how long is this software is gonna be implemented to the healthcare?
Or, no, sorry. Like how long does it take for the model to?
To predict the CT scan.
Yeah.
It really on my computers, if I have the CT scan, it only takes like a minute.
That's pretty impressive.
Yeah, thank you.
Yeah.
Any more questions? All right. Thank you, everybody.